Good morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jim Stallings.
Do you or someone you know have black lung or suspect of having black lung? We're going to give you some information on that as well as other lung problems today here on Health Talk, brought to you by Mon General Hospital. Our guest is Dr. Roger Abrahams. He's a pulmonologist on staff at Mon General Hospital. Good morning.
Good morning.
And welcome back. It's been a few years since we've had you in, but I remember you, and you were a frequent guest a few years back here on our health show. So thanks for coming back. Let's talk about black lung, and most people in the area know that that is derived from many people working for years in mines and breathing in that coal dust.
Yes, a lot of people don't realize that actually the coal dust can cause two diseases. One of them we call pneumoconiosis, which is a disease that shows up on a chest x-ray. But the one a lot of people don't realize is what we call industrial bronchitis, which actually does not show up on a chest x-ray, but you can pick it up on breathing tests.
Now, the lungs do a pretty good job of expelling foreign materials, I thought.
Yes, the lungs have a very good defense system. And actually, most people who are exposed to coal dust do not get significant disease from the coal dust, but there's a small population of people who do. And it's very similar with cigarette smokers. Probably 80% of the people who smoke cigarettes don't get COPD or chronic obstructive pulmonary disease.
And so do we know why some people are susceptible to this and some are not?
You'd make a lot of money if you could figure that one out. No, nobody understands. Just some people seem to be susceptible to the effects of the dust. And so with coal miners, what happens is that the dust starts to accumulate in the lung, usually the upper part of the lung, and the body reacts to it by forming little nodules or scars. And that's what we call the pneumoconiosis.
I'm sure MSHA does studies on this all the time, and they've probably looked at heredity because, you know, a lot of sons follow their fathers into the mines who followed their fathers into the mines. So do we know if it's passed down from generation to generation? If my dad had black lung, am I likely to get it as well?
There's no strict hereditary predisposition, but some people do have a slight hereditary predisposition.
I think Kay's father had black lung, didn't he, Kay?
Yes, he did, Jim. He had black lung, and he also smoked, so he had a double whammy on him then.
When were you aware that he was starting to have lung problems when you were young? What were some of those symptoms? The coughing?
One thing, he spit up a lot of black stuff. It seemed like when he'd blow his nose and those things, you could actually see what he was going through. It would be darker. And of course, just his coughing every morning. I remember him getting up trying to clear his throat and clear his chest in the morning.
So the way that the lungs attract oxygen, which we need, is the coal dust block your lungs from absorbing the oxygen, and it's kind of suffocating you a little?
Well, what happens with the pneumoconiosis, these little nodules, they start to coalesce. First of all, the early disease, what we call simple co-workers pneumoconiosis, generally, if you detect it at that stage and you take the patient away from the mine and they don't have any further exposure, the disease does not progress. And that's why the surveillance chest x-rays are so important to catch it at that stage. But if you don't catch it at that stage, these small little nodules that are like the size of BBs or green peas, they start to coalesce into bigger nodules. Once it gets to that stage, which is what we call complicated or progressive massive fibrosis, the disease can progress even if you don't have further coal dust exposure. So that's why the surveillance x-rays are important to catch it in the simple stage when you can prevent it from progressing.
So all miners will end up with this disease if they work in the mines. Of course, what we have to understand, too, the mines today is completely different than the mines that my father worked in back in the 30s.
Yes, and most miners will not get the disease.
Sure.
Yeah, so he said it was like cigarette smoking, Kay, when you were out of the room, is that, you know, all smokers, not all of them get some kind of lung disease. You know, a certain percentage of them does.
See, I thought they did. It's some sort of a lung disease.
No, actually with smokers, probably 20% will get significant COPD. The rest it really doesn't affect. And doctors don't understand why those people seem to have a predisposition to develop disease.
That's interesting, because people that have smoked all their lives, but you still hear that cough, it seems. And also, it's not just the lungs. I think with cigarette smoke, it's what it does to the overall body.
Oh, absolutely. I mean, we think about cigarette disease and how it affects the lung, but it can cause lung cancer, and a lot of people don't realize how drastically it affects the heart. It makes you much more susceptible to coronary artery disease and heart attacks.
So these early stages of black lung, you said, can be reversed. So I know they probably test minors all the time or require them to get tested all the time. If they start wearing masks, can they continue to mine?
Well, it's the air handling system in the mine that's supposed to keep the dust exposure down. But to answer your question, if they did wear a mask and it reduced the dust exposure, then they could. But I doubt they would allow miners to work with masks on like that.
Yeah, we hear that, Joe, he died of black lung. Does it cause death?
Oh, absolutely. Yeah.
There's no cure for it.
That's
once
correct.
It's in those advanced stages.
Correct. The idea is to catch them in the simple stages where you can prevent it from progressing by taking them out of the mines.
Do they eventually suffocate?
Well, what happens, the volume of air in your lungs gets restricted. So your volume is reduced, and it also affects the ability to absorb oxygen into the bloodstream.
Yeah, they literally they can't breathe in and out. It just comes where they
Yes, it's restricted. So you may get half the volume of air in progressive disease, more advanced disease.
Ventilators, do they work? I mean, if you get to the point where you can't breathe on your own, you're going to have to go on a ventilator, aren't you?
Well, what you would do is go on supplemental oxygen. You've seen people walk around with nasal oxygen. That would be the treatment.
But my father did end up on a ventilator, but not for a very long time.
Yeah, my grandmother did too. She wasn't a miner, though. She had emphysema, which I guess is a whole different topic. But we are going to talk about the effect that cigarettes have on the lungs. How can people stop smoking? And why is healthcare so expensive? That's one of the topics you want to talk about today?
Sure.
But maybe we should just get into that right away. But we'll continue with our Health Talk show coming up in just a moment, brought to you by Mon General Hospital on WAJR.
This is Mon General's Health Talk. If you have a health-related question, call us now at 304-296-0041.
Pulmonologist Dr. Roger Abrahams is our guest on the show. Your phone calls are welcome at 304-296-0041. Okay, why is healthcare so expensive? This is a question we all ask ourselves every day. This is a multifaceted answer, I'm sure.
Well, I think the problem is that the control has been taken away from the consumer, who is the patient. And insurance now is the one who is actually paying the bill. So I'm going to give you an example. There's a chemotherapeutic agent available today. And it's for stage 4 end-stage lung cancer. And it has been shown to prolong your life for an average of 2 months. This medication costs about $100,000 a year. It's covered by your insurance because it's proven to be effective. So most doctors want to do the best they can for their patients, and they'll prescribe this medication for the patient, and the insurance pays for it. Now, if you were to go to the consumer or the patient, and the patient was paying for it, and you told the patient that you had this medication that will cost $100,000 to prolong your life for 2 months, most patients would say, I would rather give that money to my family, or I'd rather just go out and enjoy the rest of my life. But what we end up doing is it's free for the patient, and so the insurance company pays for it. And that's, I think, is the driving force between the expense.
But aren't insurance companies now negotiating with doctors on the payment?
Yes, and the insurance companies are getting smart, and they're starting to do that now, but it is not there yet.
Yeah, so most of us think that if the insurance company's paying for it, then we're getting our health care for free. But nothing's ever free, they say, right?
Right, and I would rather have the decision made by the patient, not by the insurance company.
But whose fault is it? Whose fault is it that medication's $100,000? It's not the insurance company's fault. It's not my fault. Where does that cost come from?
Well, I think there are a lot of reasons. One is that it's very expensive to develop a medication. A pharmaceutical company may put a lot of money into medications, and 90% of the medications fail. And so only a small percentage of the medications actually go out to the market. And so they have to recuperate all the money they've lost on their failures.
So it's the pharmaceutical companies that set that price.
Yes.
Nothing in the medical field at all would have anything to do with setting the
They
price.
have to
just the
recover
company.
research and development.
Exactly.
Huh. It always seems that it is less expensive in other countries, that the United States is one of the most expensive when it comes to health care.
Well, there may be a little bit of cost shifting there, meaning that the pharmaceutical company, if a country can afford to pay more for the medication, they're going to charge that country more.
Yeah, and they say when you buy in bulk, it lowers the cost, but I don't know. It's all very confusing to me, but it's not only $100,000 medicines. I mean, there are medicines that are $1,000 to $12,000 that I've heard, and
That's
I can't
too
imagine.
much for a lot of people.
I mean, it's too much. Yeah, exactly.
Now, supposing you have a disease and there are several medications that could treat it. The doctor is going to prescribe the medication that works the best. Now, the medication that works the best might cost $1,000. The one that's slightly inferior might cost $100. But what you end up getting is the one that costs $1,000.
What about the patients that don't have the insurance?
Well, a lot of patients, if they can't afford the medication, then those are the ones who are probably going to go for the cheaper one, which may still work, but may be slightly inferior. And that's actually what I like about a health savings account. And the way that works is that you let's say, get a $5,000 deductible on your health insurance. That means that you pay the first $5,000 of your health expenses. But the health insurance is much less expensive. So the money you save by not putting it into health insurance, you put into a savings account. And then you're the one actually making the decision of how you want to spend your money. And you're going to shop around and you're going to find the cheapest way to use your dollar.
That sounds like almost automobile insurance. The higher your deductible, the lower your monthly payment.
Exactly.
Or premium.
But with the money you're saving, you're actually putting it away into another account that's used specifically for your health. And there are tax advantages of that also.
Can we pull that right out of our salary? I mean, when we get our paycheck, can they go ahead and just deduct that? Because you know how it goes. We say we're going to do something, but when the end of the month comes, we can't always do it.
Yes, and actually that's what we do in my office. But it's up to the individual employee whether what they want to do with that money. So you can't force them to put it into a health savings account.
Our number is 304-296-0041.
I just wondered, who do we talk to about that, the health savings account? Do we talk to an insurance company? Do we talk to our doctor? How do we get started? Yeah.
Yeah, both the employer and also the health, whoever is sponsoring your health insurance, they have these ask for a high deductible plan associated with a health savings account.
Okay.
304-296-0041. Pulmonologist Dr. Roger Abrahams is our guest. We'll take our final break. Be back in just a moment.
The doctors, the latest news and procedures. Your local health connection is Mon General's Health Talk. If you'd like to be on the show, call 304-296-0041.
Dr. Roger Abrahams, our guest this morning on Health Talk, and we have a call from Ben. Hi, Ben. You're on with Dr. Roger Abrahams. Go right ahead.
Good morning, Dr. Abraham. I just wanted to maybe give a pharmacist perspective on the drug cost interactions. I listen to my wife talk in and out every day about the problems with getting people medicines, and the negotiation actually it comes between the the doctor and the pharmacist and the insurance company. The drug companies never have to negotiate with their prices.
Yeah, okay. So it's the doctor's services and the insurance that are negotiating. The cost of medicine is non-negotiable?
Yeah, right now there's a big fight between Walgreens and Express Scripts because of Express Scripts dictating what they're going to pay, and what they're going to pay is not enough to even cover the medication. See, Walgreens has to pay and Rite Aid and CVS and whatever else has to pay their amount to their pharmaceutical companies no matter what.
All right.
Of course, that's all based on a contract. But Express Scripts is where they're getting the money from the people and from the insurance companies, and so they're actually making a stand for the people to keep making their own decisions. Because, you see, when you need that $100,000 medication, and then you go to your insurance company and you say, Well, they're in a sense negotiating with your life. They're not, they're not leaving that up to you. It's just whether it's in their hands as to whether they're going to pay or not.
All right, Ben, do you concur, Dr. Abrahams?
Yes, and that's why it's so important to leave the healthcare decisions in the hand of the patient, not in the hands of the insurance company.
All right. Thank you for your call. Let's talk about cigarette smoking and a way for people to quit. You hear so many different methods. Some people can do cold turkey. Most people cannot.
Well, there are pharmaceutical ways to help you quit, and there are also psychological ways. A lot of people light up cigarettes, and they don't even know they're smoking them. The phone rings, they light a cigarette, and they don't know. So the first thing they could do is make themselves aware that they're smoking the cigarette. Put your cigarettes in a different pocket, in a different location. So every time you light up, you know that you're lighting that cigarette. And then you can make a choice. Do I need this cigarette now, or can I wait and have one later? There's psychological ways of positive reinforcement. I tell my patients, if you, let's see, figure out how much a cigarette costs, and if you cut your smoking back by 2 cigarettes a day, take that equivalent money and put it into a glass jar. And every day you put that money into the glass jar and you watch the money build. It gives you positive reinforcement. It makes you feel good about what you're doing. And then after 6 months or a year, you take that money and go out and treat yourself to something nice.
Yeah, it's interesting, the psychological aspect of that, because a lot of people, it's the holding of something between their 2 fingers, or the habit of doing that. It's hard to break.
Right. And then there are the tobacco replacement therapies that work, and a lot of these are over the counter now. You can get the electronic cigarettes, you can get the patches, and then there are other pharmaceutical medications such as Chantix or Zyban that also will help.
The electronic cigarettes, it was somewhat of a debate here, because when the Montague County smoking ban went into effect, we were told that was also being enforced in bars, not being able to smoke that. Since then, I learned that United Hospital Center in Bridgeport allows smoking of electronic cigarettes in the hospital. Have you ever heard that?
No, I haven't.
But some patients, I guess, are treated that way. How does that work? It gets them off of real nicotine and onto something else?
Yes. Well, the idea is to try to get them off the tobacco.
Yeah. But are there harmful products in the electronic cigarettes?
I don't think so.
It's a vapor, right? It's not really a smoke.
Yeah, I'm not actually sure how it works.
Yeah, interesting. But the other medicinal ways that we hear are the patches. Is that the Chantix you were talking about? Is that a patch?
No, the patch is a actual tobacco. It's the nicotine that's absorbed.
Yeah, but then you decrease the amount of nicotine through a series of patches.
Yes, so frequently you might start with 21 milligrams, and then you reduce it to half the dose, and then to 7 milligrams, and then you stop.
Nicorette gum, good, bad?
Nicorette gum is good too, and the way that works, you take 1 or 2 chews, it releases the tobacco, and you sort of keep it parked in your mouth, and when you want a little bit more, I keep saying tobacco, I mean nicotine. When you want more of the nicotine, you chew the gum again.
So that's something they could be doing in bars right now instead of smoking in bars and restaurants. Take a little bit of Nicorette in with you, huh?
Yeah.
You won't disturb anyone else by chewing it.
Instead of putting a chew between your cheek and gum, you can put a Nicorette between your cheek and gum.
Such a logical thought.
Yeah, but there is help for people who really want to try smoking,
Yes.
right? Stop
stopping.
smoking.
Yeah, and that's the key. You have to make up your mind that you want to stop. If you've made up your mind that you want to stop, then there are ways the doctor can help you.
Well, thank you so much for the information this morning.
You're very welcome.
We certainly appreciate it. Dr. Roger Abrahams, pulmonologist on staff with Mon General Hospital. And this show